Hi, this is Mark Struthers. Today we want to talk about the different skill set that you need when you're doing NICU portable radiography. The NICU environment is carefully designed to support the delicate needs of premature and critically ill newborns. It's not just about high-tech equipment, it's about creating a space that mimics the womb as closely as possible while promoting healing, development, and emotional connection. In the neonate intensive care unit, every action carries a weight. The smallest patients, fragile, premature, and often fighting for survival, depend on us to bring precision, safety, and compassion to every exam. Portable radiography in this environment is not just about producing an image, it is about protecting life while capturing the information that guides critical decision-making. It's important to understand that neonates or preemies have underdeveloped organs and fragile tissues, making them susceptible to injury. Their immature immune systems also increase the risk of infection, requiring careful handling and monitoring. Neonates are highly sensitive to changes in temperature, noise, and light, which can cause stress and physiological instability. Minimizing environmental stressors is essential during ICU care. A portable radiograph is a stressor. Factors such as invasive lines, fragile skin, and limited mobility increase neonates' risk of injury and infection. Proper aseptic technique and gentle handling reduce these risks. Portable imaging is indispensable in ICU care, but it comes with hidden costs of stress and risk. Handling and positioning are not trivial. They can destabilize fragile infants. Radiation exposure, though individually small, must be managed with ALARA as low as reasonably achievable principles. Improper handling or positioning can cause musculoskeletal injuries due to the neonate's fragile bones and joints. Supportive techniques reduce the risk of trauma during movement. Maintaining stable body temperature is challenging in neonates. Handling and transfers can lead to heat loss or overheating, so thermal support and monitoring are vital. Medical devices such as endotracheal tubes and intravenous lines are critical, but vulnerable to accidental removal during handling. Secure fixation and cautious movement help prevent complications. Using appropriate positioning and support reduces pressure points and helps maintain the physiological stability of the neonate. Techniques should accommodate the neonate's fragility and medical needs, using supports and positioning tools. Devices must be firmly secured before movement to avoid dislodgement. Regular inspection and careful handling ensure continued device function and patient safety. Limiting noise, light, and unnecessary handling reduces neonate stress responses, promoting better physiological stability and better recovery outcomes. Clear communication between the ICU staff and radiography is important. Clear communication before and during handling ensures coordinated efforts, reduced risks, and enhancing patient safety. Like all equipment, there's many vendors out there, and you should familiarize yourself with each one of the units that you have to work with in the NICU as far as the isolates or the incubators are concerned and other equipment. Utilizing equipment designed for neonatal care such as incubators and transfer aids support safe movement and maintain physiological parameters. Adherence to established protocols guidelines and safety practices reduces errors and protects neonates from avoidable harm during ICU care. Prior to taking the images, you need to familiarize yourself with the type of incubator that you'll be using and whether you'll be using either under baby or the tray method for placing the receptor. The highest quality images and the clearest images are done under the baby because there is nothing to impede the X-ray beam. These are good for critical line placements, tube placements, or when maximum detail is essential. The other method, the tray method, where there's a built-in tray in the incubator, we're going to use that for our receptor and then actually X-ray through the incubator itself, which of course degrades the image and causes attenuation of up to about 10 to 45%. The tray method is acceptable for follow-ups and stable babies where small losses in sharpness are tolerable. Direct under baby placement is preferred when maximum clarity is desired. If tray use is unavoidable, the best practice is to slightly increase your mass and increase your distance, your SID, to balance dose and clarity. Comfort pads and tray plastics can attenuate the beam by 6 to 15%, usually the exposure at 60 kVp, depending on the materials, of course. Thicker, dense trays, some are even thicker than usual, can attenuate up to 45% of the dose. Let's take a look at the comparison between the tray method and the direct under baby method. We've talked about it briefly previously. The main thing is that under baby method is going to give us the best quality image, the lowest dose. It's going to be slower because it's going to require working with the nursing staff. The other method, the tray method, is used for routine, everyday, not well because they're in NICU, but babies that are not in distress. And so what we're looking at here is having the baby undisturbed in the incubator where we can control both the humidity and the temperature. It's also a closed environment, so there's lower contamination risk. When going to NICU, check with the nurse first and verify the neonate's ID and the correct exam that should be taken. You need to also set your exposure factors in advance for your KVP and your mass according to your neonatal technique chart before positioning. You should park the mobile unit at an angle to the incubator so the tube can align properly without bumping the equipment. Here we get a look at the tray method. Notice how we can pull the tray out to put the image receptor in. The X-ray tech is being helped by the nursing staff in positioning the baby and putting the receptor in while they get the portable ready. Here we're looking at the under the baby method. Notice that they're not lying on a pad and you're not shooting through an incubator. When timing your exposure, you should watch the neonates because they're tummy breathers. Breathe with them when you can and then use your own breathing rhythm to make the exposure. When the abdomen rises, the lungs are full for the chest X-ray. Premature infants are unique because they are still undergoing organogenesis and rapid cell differentiation outside of the womb. Radiation effects depend on dose, timing, and tissue sensitivity. So let's take a look. If we're looking at the central nervous system, the brain is highly radiosensitive between 8 and 25 weeks of gestation, and radiation during this period can impair neurodevelopment, causing lower IQ or an increase of later cognitive defects. In the hematopoietic system, the bone marrow is rapidly proliferating, making it vulnerable to DNA damage and increasing lifetime cancer risk. The environment of the ICU or NICU is different. It is often a crowded environment with incubators, monitors, IV poles, ventilators, and more. It's also a busy workplace. And the patients are neonates that are fragile and often intubated or connected to multiple lines. Radiographers use manual techniques in an ICU. There is no AEC or APR. Automatic exposure control does not exist here. We have different areas that we control when we use manual technique. They are collimation, distance or SID, and also exposure control over our settings of KVP, MA, and time. Remember, MA is the radiation, and of course, radiation is on for a certain amount of time. That's mass. And there's a balance called the 50-15 rule between KVP and mass. We can actually increase the KVP and decrease the mass when we're imaging in the neonate ICU to get a better quality image with less radiation exposure to the patient. Here we see an infant on a receptor. And although the image that was produced is not collimated, notice the sharpness and the clarity. This is because we're not shooting through an incubator, the plastic of the incubator, the baby's bed, or a grid. We simply have the receptor and the baby. Other things that we must look for when we're making our exposure are artifacts that can be caused by where the lines and the tubes are superimposed on the child, or if the child is moving and causing a blurred motion. We need to be able to wait and get the X-ray at the precise time. Portable neonate imaging of the same region at different times to monitor condition changes requires radiographers to consistently replicate the technique, including the same SID, KVP, mass, and positioning, and notate the time to ensure accurate comparison and assessment of improvement or deterioration. The radiographer should also use soft rolls or immobilizers or nesting devices to maintain the posture and position of the patient and reduce motion blur. In the NICU, radiographers must rely on carefully selected manual exposure techniques rather than automatic settings to ensure radiation is minimized to still developing organs while maintaining the diagnostic quality essential for clinical decision-making. If a repeat is required, it should only be done for clinically actionable deficiencies, such as a line tip location. There must be a standardized technique chart. Keep a living, weight-based chart posted on the NICU unit in the portable console. Audit and update quarterly with physics and radiology input. This practice decreases unnecessary organ exposure and total dose area product. Meticulous collimation also reduces the dose area product substantially. QI programs show large reductions in per exam DAP and cumulative monthly DAP when collimation and targeted orders replace infantograms. After making exposures, track your exposure indices and dose area product trends. Monitor the EI target bands on the detector and the DAP per exam. Use serial trend reviews for protocol tuning. When doing extremities, you need to collimate narrowly and support the limb to minimize motion. Also, you need to remove any immobilizers like the soft rolls only if it is safe, and document your positioning. Here we see someone took an infantogram instead of an exposure for the extremity, and notice that there's a big difference in the extremity exposures. Never try to position and do an exam in the NICU by yourself. Always have the nurse that is attending the child assist you in doing the examination. Remember, there are risks of handling and positioning these neonates that the nurses are well versed in, and you are not. Obviously, the neonate nursery is supposed to simulate the womb for the infant. Therefore, we have to worry about, when we do imaging, creating a different environment, bringing stressors into that environment, such as bright lights, noise, and interruptions to sleep cycles. It's up to the radiologist to determine whether a chest radiograph is normal or abnormal, but it's up to the radiographer to make sure that the image is optimal in its quality. For years in the past, the normal thymus, or neonatal thymus, was often mistaken for a mediastinal mass or pneumonia on chest x-rays because it can appear large, lobulated, or asymmetric. Clinicians sometimes thought it was a tumor or pathologic enlargement. Neonates are small, and also everything associated with them is small and tiny. If we take a look, umbilical catheters, PICC lines, and endotracheal tubes are often very tiny. Tubes are only 0.5 to 2 millimeters in diameter. That's about 500 to 2,000 microns. And some feeding tubes are even thinner, closer to 3 to 500 microns. So let's look at exposure sensitivity. A small increase in kVp can wash out these slender lines, making them nearly invisible against the mediastinum or the abdomen. Too low an exposure and noise overwhelms the fine detail. Neonatal organs are small and radiographically crowded. A misplaced catheter tip can be hidden by the cardiac silhouette or liver if the exposure isn't optimized. So why does positioning matter? Well, studies show that PICC tips can shift by 2 to 3 vertebral bodies simply with an arm adduction or abduction. A hip flexion can drive a lower limb PICC deeper into the inferior vena cava. Even a slight projection distortion or a slight rotation of the body can make a catheter appear to be in the atrium when it's actually in the inferior vena cava, or mimic malposition in the portal system. And when you're talking about artifacts and different things, even skin folds, a subtle fold in the skin can mimic a pneumothorax line, especially if the exposure is high and the contrast is reduced. In neonatal radiography, exposure and positioning are magnified in their consequence. A 1 millimeter shift on the image can represent a life-threatening misplacement in reality. Our job is to make the invisible visible without adding unnecessary dose. A very common look to a new neonate chest x-ray is the ground glass appearance. The ground glass appearance on a neonatal portable chest radiograph is a classic but non-specific finding. The alveoli collapse, called atelectasis, and the hyaline membrane formation diffuse under aeration. The result is X-rays pass through the partially airless lung tissue, creating a hazy or ground glass appearance density rather than the crisp, black-looking aerated lung. Air bronchograms stand out because the bronchi remain air-filled, and against the hazy background, they show up very well. In preterm infants, the lungs lack surfactant, which normally reduces surface tension and keeps alveoli open. Without surfactant, alveoli collapse, which is atelectasis, and the lungs fill with fluid and cellular debris. This widespread partial alveoli collapse and fluid accumulation scatters X-rays, producing the ground glass look. TNN, or transient tachypnea of the newborn. This is a self-limited respiratory disorder caused by delayed clearance of fetal lung fluids after birth. It's transient, in other words, it's short-lived, usually resolves within 24 to 72 hours. And tachypnea means rapid breathing, greater than 60 breaths per minute. Sometimes we can see small pleural effusions. Meconium is the baby's first stool, thick, sticky, and tar-like. When aspirated, it can obstruct airways and cause an inflammation. Just like adults, neonates can have collapsed lungs or pneumothoraxes. And just like in adults, they can be life-threatening. When the mediastinum shifts or a mediastinal shift is occurring because of tension from a pneumothorax, it is life-threatening. In supine neonates, air may collect anteriorly. Subtle signs like a deep sulcus sign, which is the abnormally deep costophrenic angle, help to show what was going on with the pneumothorax. What happens when the lungs are okay? There's air in there and it's just fine, but we see a lot of air in the mediastinum. So we have a neonatal pneumomediastinum. And we get what's called the angel wing sign. Bronchopulmonary dysplasia. This is a chronic lung disease of prematurity. It's not present at birth. It develops as a complication of earlier lung injury, such as RDS, infection, or mechanical ventilation. Here we see a congenital diaphragmatic hernia, a development defect in the diaphragm that allows abdominal organs like the stomach, intestines, liver, and spleen to herniate into the thoracic cavity. It's most commonly left-sided. Now that we've seen some of the more common variants of pediatric neonate ICU chest x-rays, let's take a look at some of the devices that we need to be able to visualize and where they should be. Here we see an endotracheal tube. Notice it goes down, but you can always check on pediatrics just like in adults. It needs to be above the carina. If we push the tube down too far, it'll go down the right mainstem bronchus and actually collapse the lung. The tip of the endotracheal tube should be in between the thoracic aperture and 1 centimeter above the carina. The tip travels downward if the neck is flexed or upward if the neck is extended. The most common malpositioning is in the right mainstem bronchus because of the shallower angle of the right mainstem bronchus. Here we see a good positioned tube in a patient with a pneumothorax, though, on the left. A PICC line is a peripherally inserted central catheter, and they're used in NICU because the fragile neonates often need long-term, reliable intravenous access that you can't get with standard IVs. It's a pediatrically peripherally inserted central catheter. It is long enough to reach the large vein that gives blood to the heart. It is used when a child needs medication and nutrition through the veins over a long period of time. Here we see peripheral inserted central catheter lines, or PICC lines. They're positioned in the great vessel, preferably in the superior or inferior cava vein, or vena cava. Let's say you are asked to demonstrate the umbilical venous catheter. Where would it be and how would it look? Well, let's take a look here. A radiograph, a portable chest/abdomen x-ray, is obtained to confirm the tip position. For a UVC tip, the tip should lie at the IVC-RA junction, about T8 and T9. For an arterial or a UAC tip, it should lie in the high T6 to D9 or low L3 to L4 position, but not mid-aorta. Malposition can lead to complications. The umbilical cord has two arteries, thicker walls and smaller lumen than the one vein in the umbilical cord, which has thin walls and a larger lumen. The umbilical venous catheter is inserted into the vein and the arterial catheter into the arteries. Here we see images of both umbilical venous catheter and venous arterial catheter being used. An umbilical vein catheter should pass through the umbilical vein into the left portal vein, then through the ductus venosus into the hepatic vein and the inferior vena cava. The tip should be at the level of the diaphragm, and if not, we have a malposition, which can cause lots of problems, including not having the ability to get medication into the system. Anybody who's worked in surgery is pretty used to endotracheal tubes and also may be used to chest tubes. And preemies have chest tubes as well. Chest drainage tubes are placed in case of respiratory distress caused by pleural fluid or pneumothorax in order to allow sufficient expansion of the lung for the ventilators. An NG tube, well, where should it be placed? Obviously, the NG tube should be the nasogastric tube into the stomach. So the tip should be in the stomach so that they can feed the child. Now let's talk about one thing that really is aggravating is the idea that portable x-ray machines are portable, which means they are used all over the hospital. Even if we have one that is dedicated to a room, it still needs to be cleaned before use and after use. So let's talk about storage and cleaning of portable equipment in the neonate ICU. The best practice for storing portable equipment and effective cleaning and disinfection protocols need to be followed religiously. Proper storage of portable medical devices used in the neonate ICU is crucial for ensuring quick access and minimizing the risk of damage or contamination. This includes a designated storage area, clear labeling, and regular inventory checks to maintain organization and operational readiness for most emergency situations, whether it be NICU, ICU, or the emergency room. The cleaning and disinfection of portable equipment in the neonate ICU must follow strict protocols to prevent healthcare-associated infections, especially with these immunosuppressed preemies. This involves using approved disinfectants, maintaining a cleaning schedule, and training staff in hygiene procedures to safeguard vulnerable newborns from potential pathogens.
This is Mark Struthers, and I want to thank you for your time and for your attention. Please subscribe to the Mark Struthers channel. We look forward to doing more projects for you about medical imaging and other areas of interest. Again, thank you for your time and your attention. This is Mark Struthers, and I want to thank you for your time and for your attention. Please subscribe to the Mark Struthers channel. We look forward to doing more projects for you about medical imaging and other areas of interest. Again, thank you for your time and your attention.